Good afternoon, everyone. Welcome to our February Public Health Grand Rounds on measles, maintaining disease elimination, and enhancing vaccine confidence. My name is Dr. Tanya Telfair LeBlanc. I'm with CDC's Office of Science. Thank you so much for joining us today. Public Health Grand Rounds has free continuing education available for physicians, nurses, pharmacists, and many other health professionals. The course code is PHGR10. Please see our website for additional information on continuing education credits. Here's our continuing education disclosure statement for the session. Grand Rounds is available on the web and all of your favorite social media sites. Please send questions to Grand Rounds CDC. At the end, we'll try to work your questions in, and Susan will allow a wonderful question and answer session at the end. So send your questions. Want to know more about today's session and other public health Grand Rounds sessions? Please visit Grand Rounds at cdc.gov for information, resources, including a podcast that we call Beyond the Data, and as well as a glossary of terms for each session. And we partner with the CDC Public Health Library to assemble scientific articles on each topic. The full listing is available at cdc.gov Science Clips. In addition to our outstanding speakers today, I'd like to acknowledge the important contributors. The individuals are listed here, but we especially like to recognize Miss Tiffany Smith, who was invaluable at putting this whole thing together and worked with us from the very beginning to the end. She was absolutely a jewel. It is now my pleasure to introduce to you today our Director of the Science Office, Dr. Rebecca Bunno.
Good afternoon, everyone, and thank you so much to those in the room and those who've joined us remotely. I want to start by just recognizing the many CDC, state, and local public health staff who are currently doing critical work on coronavirus or COVID-19. I know many in the room are also helping to cover for those who are deployed, so thank you to all of you as well. As we are seeing in the unfolding events as COVID-19 spreads, disease importations are a constant threat in today's interconnected world. Measles, one of the most contagious infectious diseases, was eliminated from the United States in 2000 thanks to decades of robust and successful vaccination programs. However, the global increase of measles in recent years, in addition to increases in vaccine hesitancy, pose a risk to U.S. elimination, especially when unvaccinated travelers acquire measles abroad. In 2019, the U.S. saw the highest number of measles cases in a single year since 1992, with nearly 1,300 confirmed cases. Over 73% of these cases were linked to outbreaks in New York, affecting undervaccinated communities. Sustained transmission of almost 12 months nearly led to the loss of our nation's measles elimination status. Today's session of Grand Rounds will focus on measles in the United States and the response to and lessons learned from the outbreaks in New York in 2018 to 2019. You'll also hear about the CDC's national strategy for strengthening vaccine confidence and increasing vaccination coverage to protect our nation from vaccine-preventable diseases like measles. The 2019 measles response in New York and in New York City and beyond is an example of the best of public health. We will need to draw on that kind of talent and that kind of commitment as we collectively respond to today's challenges with COVID-19. On that note, I will pass it back to Dr. LeBlanc to open up our session. Thank you again.
Our first speaker today is Dr. Manisha Patel, who we affectionately refer to as Mo. She is a medical officer and a domestic measles team lead with NCIRD. Dr. Patel?
Good afternoon. So this first presentation is going to cover measles in the United States. Measles is one of the most contagious of the vaccine preventable diseases. In fact, a single case of measles can infect 12 to 16 other people within a totally susceptible population. It's an acute viral rash illness that classically presents with high fever, cough, coryza, or runny nose, and conjunctivitis. The incubation period is 10 to 14 days, but rash can appear as early as 7 days and last or as late as 21 days. And the infectious period starts 4 days before the rash appears and through 4 days after rash onset. And the rash typically appears on the face and the hairline and then spreads downwards. Measles complications are more common in younger children and adults and can range from less severe, like otitis media, to more severe complications like encephalitis and death. Subacute sclerosing panencephalitis is a rare but fatal neurologic complication that occurs 7 to 10 years after the initial measles infection. And it typically presents with these minor behavioral changes that progress with myoclonic jerks and dementia and eventually to death over the course of months to years. Usually it's children who are infected when they are less than 2 years of age who are at highest risk. This is a really devastating complication. Fortunately, the measles, mumps, rubella, or MMR vaccine is highly effective against measles and its complications. It has a 1-dose vaccine effectiveness of 93% and a 2-dose VE of 97%. It has an excellent safety profile. Common side effects such as fever and rash are usually mild and resolve spontaneously. Serious adverse events are extremely rare. Children and adolescents need 2 doses of MMR, and most adults need only 1 dose of MMR unless they have other evidence of immunity. High-risk adults, such as healthcare personnel, post-high school students, and international travelers need 2 doses. Vaccination of U.S. residents traveling abroad is really critical. And as you will see later in my talk, they account for the majority of measles introductions into the United States. So 2 points about travel. First, travelers 12 months of age or older should have 2 documented doses of MMR vaccine before they leave for their trip. So this means that you can decrease the interval between the first and second dose to as short as 28 days if you need to. And then the second important point is that infants 6 to 11 months of age should receive 1 dose of MMR before they travel. This dose does not count as part of their routine recommendations, and so they will need 2 doses of MMR after they turn 1. So high vaccine effectiveness and the excellent safety profile allowed for the rollout of several key policy changes / initiatives in the 80s and 90s that increased MMR vaccine coverage in the United States. This includes the recommendation of the second dose of MMR in 1989, the implementation of the Vaccine for Children's program, which allowed for wider access to vaccination, and commitment by the Pan American Health Organization and other countries in the region to stop endemic measles transmission through large-scale vaccination efforts throughout the Americas. And all of this led to measles being eliminated in the United States in 2000. So what is really key for measles during the post-elimination years, which is defined as 2001 and on, is that most measles cases are in unvaccinated persons, and this is shown here in orange. The other important point is that the highest incidence is in infants who are 12 to 15 months of age. And this is really important for providers to be aware of so that they are vaccinating infants against measles as soon as they turn 12 months of age. So I mentioned that the majority of, or 2/3 of measles importations are among US residents in more recent years. And the fact that these importations are occurring in unvaccinated US travelers who are acquiring measles infection abroad and then developing disease and, in some instances, transmitting to others when they return to the United States really underscores the importance of ensuring that providers are vaccinating their patients before they travel internationally. So, even though the US is continually getting measles importations, and there have been 747 importations from 2001 through 2019, most importations are not associated with outbreaks. And this has to do largely because of the high nationwide MMR vaccination coverage in the United States, but also because of the extraordinary efforts from state and local health departments who are responding rapidly to every single case. So in general, the reported measles incidence has remained less than 1 per million, and that's shown by the red dotted line there. And this is an indicator of good measles control. But you can see that in more recent post-elimination years, we are seeing an increase in the number of reported measles cases, particularly in 2014, 2018, and 2019. So why is this happening? Well, one major contributor for the increase in domestic measles is the increase in global measles, which tripled in 2019. And all of the WHO regions have reported measles cases, but the European and African regions particularly had major outbreaks occurring in the Ukraine and in Madagascar, which is contributing to that blue region for African region and the red for the European region. So while global measles activity remains high, the United States will be at continued risk for measles. And these importations can land anywhere in the United States, but it is more concentrated in states that have major ports of entry. And then when you overlay these importations with geographic areas that are highly dense and have lower vaccination coverage, you're going to have rapid spread of measles throughout a community, leading to large outbreaks. And just as a reminder, the herd immunity threshold for measles, which is the proportion of a population that needs to be immune to prevent transmission, is high. It's between 92 and 94%. Since 2001, 158 outbreaks have been reported in the United States, but most of these outbreaks are limited in size and duration, with 5 cases per outbreak and the median duration of 23 days. But you can see that in more recent years that there are larger outbreaks that are being reported, and these shown in red are the outbreaks that are of 50 or more cases. And then if you look closer at those outbreaks, the 7 that I showed in red in the previous slide, there are 2 points that stand out. First, these outbreaks are occurring in close-knit communities. And second, these outbreaks are lasting for longer than what we had seen when you compared it to earlier post-elimination years. The last row shows the 2 outbreaks, New York City and New York State, which started in 2018. New York City and New York State were especially concerning, not only because of the large number of outbreaks that were reported, but because of the sustained duration of these outbreaks, with transmission lasting for 9.5 months in New York City and 10.5 months in New York State. And if transmission had lasted for 12 or more months, or 12 months or longer, the United States would have lost its elimination status. And Dr. Zucker and Dr. Barbeau will talk more about the various strategies that were implemented in New York to control this outbreak. So in summary, endemic measles has been eliminated in the United States since 2000. However, measles cases continue to occur in the U.S. through global importations, of which the majority are due to U.S. residents who have not been vaccinated before their travel. The recent epidemiology suggests larger and more sustained outbreaks compared to earlier post-elimination years, especially when importations and sometimes repeated importations are landing in undervaccinated communities. These outbreaks require multidisciplinary local responses to prevent further spread into these vulnerable communities. Thank you, and I would now like to introduce our next speaker, Dr. Howard Zucker, the Commissioner for the New York State Department of Health.
Thank you. Thank you to the CDC for convening this important Grand Rounds. I will tell you, it was a year-long fight against the historic measles epidemic that public health officials in New York State and New York City mobilized on two fronts. So we had the New York State Department of Health collaborate with the county health officials to contain cases in the lower Hudson Valley, and the New York City Department of Health and Mental Hygiene tackled a similar outbreak, a separate outbreak, primarily in Brooklyn during the same time period. And as New York State's health commissioner, I led the department's efforts in the lower Hudson Valley, and I will address our work and progress on that front. As a general note, all references that I make to New York State measles cases in this presentation are those that are occurring outside of New York City. So I thought it would be useful to briefly look at measles and disease prevention in New York State before this outbreak. When the United States began tracking measles cases in 1912, the disease killed roughly 6,000 people in the country each year. And about the same time, New York State launched what would become a world-class laboratory, combining research, public health testing, and science education. And the Wadsworth Center Laboratory initially focused on smallpox, on cholera, on typhoid, tuberculosis, tetanus, and especially diphtheria. In the 1890s, diphtheria alone killed 1,000 people a year in New York City. And after developing America's first system of lab analysis for the diagnosis of human disease, Wadsworth became a standard bearer in public health. And over the century, Wadsworth worked to contain and to prevent communicable diseases like measles, which was killing up to 500 people in the country before 1963. The 2018-2019 measles outbreak was the largest in New York State since the 1990s. The graph shows that cases in the state have held relatively steady since 1997. And in 2013, New York City experienced a significant outbreak that, like our recent outbreak, started with an unvaccinated traveler who had been infected while abroad. The 2013 outbreak recorded 58 cases, primarily in Brooklyn. The graph shows small spikes over this 20-year period, but nothing like what we encountered starting in the fall of 2018. So let's look at the details of the outbreak at that time. In both New York State and New York City, the outbreaks have been concentrated among Orthodox Jewish communities and traced to travelers returning from Israel and the Ukraine, where measles outbreaks have been prevalent. The first case was a visiting teenager from Israel who was unvaccinated. And in total, we confirmed 10 imported cases of measles, including 4 cases from a single family. During the outbreak, 406 cases were confirmed in Rockland, Orange, Sullivan, and Westchester counties. And in under-vaccinated, close-knit communities like those affected, the number of cases rise quickly if you don't act fast. And the county providers administered nearly 85,000 MMR vaccinations before the outbreak's conclusion on October 3rd. The diverse geography of this outbreak was definitely a challenge when mounting an effective response with local partners. The county health departments we worked with ranged in size from small to large, both in terms of the populations that they served and the department staffing. This presented the department with difficulties in assisting with case investigations and monitoring, as well as getting specimens to our public health labs. Rockland County was truly ground zero for this outbreak. The New York State Department of Health worked hand in hand with Rockland officials for an entire year. The last case of the outbreak occurred in Rockland County on August 13th, which was just 6 weeks before the deadline in which the United States would lose its measles elimination status, as you heard. And Rockland officials declared the outbreak over on September 25th. Commissioner Rupert and her Rockland County Health Department staff often worked 14-hour days, checking on more than 100 people on some days. And the county officials kept tabs on roughly 1,200 individuals known to have been exposed to the virus and deemed susceptible to infection. They also reviewed hundreds of thousands of school immunization forms to check which students had been vaccinated. Refuah Health Center was another tremendous partner in our measles fight. Refuah's CEO, Hannah Sternberg, and Chief Medical Officer, Dr. Karina Manini, shared their experiences and insights at a Grand Rounds discussion about vaccine hesitancy that the department hosted at Mount Sinai Hospital in Manhattan on June 13th of 2019. Refuah and Ms. Sternberg helped connect the department to the rabbinical leaders in Rockland County, leading to improved communications and more effective promotion of vaccination. Now, I'll run through how the department developed a successful strategy for containing and ending a quickly moving outbreak. The department's strategy consisted of 5 elements. The department's incident management system activated from start of the outbreak, healthcare outreach and communication, community education and outreach, preventing spread in schools and at summer camps, and New York State legislation. Partnership was everything in rising to this challenge. It really was. It was all about partnership, not just with county health officials, but with all the healthcare facilities in the affected county. The department worked closely with local doctors, school administrators, rabbis, federal health officials to contain the disease and increase public awareness about the critical importance of vaccination. And we worked to streamline the connection between county health departments and specimen testing at our Wadsworth lab in Albany. I can't stress enough how crucial ongoing education and outreach was in our ability to monitor and contain this outbreak. We learned to be patient but firm in dealing with communities and families. In the late spring of 2019, the department launched a PSA video in which I discussed the safety and effectiveness of vaccines. And it aired in June and then again in August. As you can imagine, schools and summer camps were a huge focus throughout 2019. Rockland County in particular held firm to its vaccination requirements in schools throughout the outbreak. And the department provided local health departments with guidance and informational flyers and posters to ensure that camp administrators knew about vaccine-preventable diseases, about vaccination recommendations for camp settings, and medical details about measles. We provided measles response playbooks and immunization record templates. We conducted an emergency preparedness exercise for department staff, and we provided a statewide webinar for camp operators and camp health directors. We were particularly proud of our preventative work in Sullivan County, where the camp population actually surges, and it was presented a heightened risk of transmission at that time. Governor Cuomo signed legislation in June to eliminate all non-medical exemptions for childhood vaccinations required for public, private, and parochial school attendance. In August 2019, we aired a second PSA video reminding parents of the new vaccine requirements ahead of the start of the school year. Now let's look a little bit at the data from our epidemiology team. On our epi curve, the colors reflect the different counties, with Rockland in gray, orange, cleverly in orange, Sullivan in yellow, and Westchester in blue. The arrows show the importation of cases, and the last rash onset was August 19th. The curve has 2 big peaks. This could reflect the unreported cases that occurred, blunting the curve in the middle, or the increased travel that occurred before and during the Passover holiday. There were also 2 importations that occurred in April. And here is a snapshot of vaccination rates over the course of the outbreak. Our base level in the state before the outbreak was 96% of school-age children are inoculated with the MMR vaccine. We improved our vaccination rates in the 4 most affected zip codes by 11%. This slide shows cases by age and vaccination status in the 4 affected counties. So most cases, about 82%, had not received any doses of MMR. Among those with 0 doses, 299, or 90%, were children. 251, or 84%, of these children were age 1 or older, eligible for MMR under the routine recommendations. An additional 31, or 10.4%, were between the ages of 6 and 11 months, eligible for MMR in this outbreak setting. And then 134, or 33%, of the cases were between 1 and 4 years of age. And an additional 34% were between the ages of 5 and 17 years. The greatest public health success in our response to this outbreak is that no one died from measles-associated complications, and there were no documented cases of encephalitis. Of the 28 hospitalizations, 6 children between 1 day of age and 7 years were admitted to the intensive care unit, and there were 2 preterm births to mothers with measles, and both babies were confirmed with congenital measles infection. So what did we learn? We learned a lot from this surprisingly long skirmish with measles. The causes of this outbreak are pretty straightforward. Measles is still common in many parts of the world. Unvaccinated people who travel internationally can be at risk. We learned it just takes one importation for measles to spread when residents of New York State are unvaccinated. The World Health Organization named vaccine hesitancy as one of the greatest threats to public health in 2019, and that proved true in New York State. And during this outbreak, the vulnerability caused by vaccine hesitancy in the state's Orthodox communities was exploited and made worse by the propaganda and activism of the anti-vaccination movement. Cultural barriers to scientific and medical communication in the affected communities were another factor. We didn't have a rapid-fire system in place for persuading Yiddish-speaking communities that vaccination was safe and would better protect the community. We experienced some lab testing limitations in that it was difficult to confirm whether IgM positive results received through lab reporting were measles cases and too late for control measures. I want to spotlight one new public health tool that originated from this outbreak. The department's Measles Watch dashboard on the New York State Health Connector provides timely information about local, about regional, and statewide, excluding New York City, measles cases and locations offering an MMR vaccination. The watch also provides immunization and exemption rates for current and previous school years, with school vaccine data updated annually. And here's our prevention game plan going forward: vigilance, partnership, and enforcement of new legislation. We are continually working to vaccinate every eligible child while educating the public that vaccination is health, and that 2 doses of MMR, as you heard, are 97% effective. We continue to forge partnerships at the community level, intermediaries who can more effectively reach families, and as we are always reaching out to parents with communications like this back-to-school flyer about the new vaccination law. We are using what we learned to perfect the efficiency of the department's incident management system should another outbreak occur, and the threat for vaccine-preventable diseases is always present, and the department is not letting down its guard. We will remain vigilant in protecting all New Yorkers from measles and other dangerous vaccine-preventable diseases. And finally, I want to recognize these individuals in the Department of Health, the affected counties, and the CDC who helped us weather the storm and develop better protocols for handling any future outbreaks of communicable diseases across the state. It was an incredible tour de force, and we all worked together to achieve our goals. And I want to thank you for the opportunity to speak with you today about our experience. Thank you.
Good afternoon. So it's my pleasure to speak with you all about New York City's experience with the 2018-2019 measles outbreak. And I think it's fitting to sort of take Howard's last statement to begin our statement in terms of the collaboration between city and state, as well as our federal partners. It was really what made this response what it was. So as an overview, I'll talk about the epidemiology of what we saw. I'll talk about the twofold response that we undertook in New York City, and then end with lessons learned and future challenges. So to begin, as Dr. Zucker mentioned, the New York City outbreak was centered primarily in the ultra-Orthodox community. And these 2 red circles highlight the neighborhoods where the outbreak was most concentrated. The top one Williamsburg, and the bottom one, Borough Park. These two neighborhoods each have roughly about 200,000 children. And as was mentioned, the first case had a rash onset of September 30th and was a child who returned from Israel. So it wouldn't be a public health talk if there wasn't an EpiCurve. So this here is a representation of the outbreak, highlighting the neighborhoods that were most affected. And so Williamsburg is, I guess, the rust color, yellow, Borough Park, and then the smaller slices that you see there paint the full picture. But really, the punchline here is that those two neighborhoods were the main sources of ongoing outbreak. And so this overlay here is a representation of the phased approach that we took at containing the measles virus. And phase one was one where we focused primarily on schools that had children documented to have had measles, and working with those schools, requiring the exclusion of non-vaccinated children or children who were exempted, who were known contacts of children who had measles. And so this was started in October of 2018, and you'll see there that in Borough Park, over the course of about 2 months, it started to turn the tide. But what we were seeing is increasing numbers in Williamsburg as well. And so phase two, then, we moved from excluding children in schools known to have exposures to excluding children in communities known to have exposures. And so this took us to over 100 schools and programs that needed to have ongoing audits, because what we found was that many of these schools had little or no technology with which to track immunization compliance. So this was a very labor-intensive component of our response. And in total, as I mentioned, there were 101 schools and child care facilities that were ordered to exclude unvaccinated students. Excuse me. 41 of them had summonses. We actually had to close 12 programs until we could work with them to come into compliance in terms of effectively excluding children who were unimmunized. And then the response culminated, if you will, with a declaration of a public health emergency that I will talk more about in a few minutes. And then the last date of onset for the rash was 7/15. So in total, transmission occurred over a 9.5-month period, but the response itself was roughly 11 months. And so in terms of the epi of the outbreak, you'll see here that the vast majority of children were in the 1 to 4 year age group, and that most of them in the greater than 12-month period were preventable cases. What we saw was a mixture of children that had no measles vaccinations to those that had actually just one dose. And so for us, it was a combination of both vaccine refusal as well as vaccine hesitancy. And then in terms of the complications as a result of the outbreak, as Dr. Zucker mentioned, the lead here is that thankfully there were no deaths due to measles and no cases of encephalitis, but we did have 8% who required hospitalizations, and our age range there was from 3 months to 66 years of age, requiring hospitalizations, 20 ICU admissions, most of whom required O2, but none needing intubation. And so for us, why did this outbreak occur? And, the punchline here is that there was low herd immunity in a densely populated, relatively closed community with large young households. And the existing coverage was low, and vaccination were delayed until school enrollment, as I mentioned. And particularly in the Williamsburg area, it's a very interesting neighborhood because though we have a large concentration of ultra Orthodox community members, we also have a fairly large and ever growing population of hipsters. So, it really is quite emblematic of New York City. And so, and so it was especially interesting to see transmission really pretty much primarily limited to the ultra Orthodox community. And, that in part was due to the increasing in religious exemptions that we were seeing. Citywide, we went from 0.5% to 1.5%. You'll see there from 2012 to 2018 school years. And in some of the schools and the communities that were affected, we saw religious exemptions as high as 28%. And so this made ongoing transmission pretty effective. And so our efforts at quelling the outbreak really focused almost exclusively on working with schools, daycares, and community members affiliated with them. So what made it complex, in addition to the cultural issues that we were challenged with, is that there were multiple exposures. Over the course of the outbreak, we investigated roughly about 2,200 people suspected of having measles, and then over 20,000 exposures with roughly over 100 chains of transmission. And so what made it challenging was that oftentimes as the outbreak grew, people were more and more reluctant to share the names of potential exposure individuals. And so that made, as Dr. Zucker alluded to, community partnerships that much more vital and central to this outbreak in terms of leaning heavily on our trusted messengers to get information out to the community. And so, as I mentioned earlier, vaccine hesitancy fueled by vaccine misinformation, cloaked in religious terms, was one of the main things that we were struggling against. And then the other thing that we found in our community was there were lots of folks who were having measles parties, which made school containment efforts that much more challenging as well. And so our response strategies focused on clinical, school, daycare. There were significant legal components to our efforts, and then the communication aspects of this. And similar to our colleagues at the state, we had activation of our agency. We had a divisional activation that started in early November, but then we had a broader agency-wide activation just before we issued the public health emergency, and that was at the last week of March. And so for the clinical, there were multiple fronts on this, and that ranged from provider education all the way through to technical assistance to try and reduce the number of healthcare site related exposures. Additionally, in terms of the school response of this, there were hundreds of school audits that were done over the course of this outbreak, and tremendous number of hours spent providing technical assistance to schools so that children could be appropriately excluded. And so here, the public health emergency was declared on April 9th. And the last time the New York City Health Department had used the public health emergency powers was back in 1901 to compel people to be vaccinated against the smallpox. We had used that power previously during, for example, H1N1, but it was more to compel practices to report adults being immunized, not compelling people to be immunized. And the public health order was limited to individuals living in the 4 zip codes most affected by the outbreak. Many of them, or let me back up. There were 232 potential violations that we ended up issuing. Thankfully, more than half of those were canceled before they were filed because individuals were able to have proof of immunity or documentation that they indeed were vaccinated during the period. And 35 of them were adjudicated through our oath system, the city's hearing system, and there's only one pending hearing. And thankfully, no one has of yet had to pay any fines, because really the purpose of this was not to penalize individuals, but to raise the urgency of needing to be vaccinated. And this was the first time in any of our ICS activations where we actually had to have a whole arm for the legal components of this. We, of course, were sued, I think about a week after the order was issued, and the motion for an injunction was denied. And the judge on this was, I think, fairly poetic. I'm just going to quote one line from his decision where he said, a pivotal question posed for this court's determination is whether respondent commissioner had a rational, non-pretextual basis for declaring a public health emergency and issuing the attendant orders challenged herein. The evidence in this regard is largely uncontroverted. And then he goes on to say, a fireman need not obtain the informed consent of the owner before extinguishing a house fire. Vaccination is known to extinguish the fire of contagion. I think he must have been a public health practitioner in a previous life. And so communication was really critical here. We leveraged the power of our religious leaders in the Orthodox community. And what we saw was that there were new community-based groups that sprouted in response to this. And the Jewish Orthodox Women's Medical Association was really pivotal in this response. They actually went door to door in Williamsburg, engaging families on the importance of being vaccinated. And similarly, we put them together with the Visiting Nurses Association and offered immunizations in the home, because we realized that over the course of this, though we did all we could to minimize stigma around this, there was a lot of stigma, I think, on both ends of the spectrum. Folks wanting to hold firm to their beliefs in terms of vaccines not being right for their children, and on the other end, members of the community trying to publicly shame folks for their beliefs. And we tried to, play the middle ground. And so offering vaccinations in people's homes was a way for us to accomplish the public health mission while allowing community members to have their voice. And information dissemination, there was, I would say, an outright war between us and the anti-vax community. They would do robocalls, we would double match them. They would do direct mailings, we would double match them. We did over 3,000 mailings. We had multiple rounds of robocalls to the point where people were calling City Hall and saying, please have them stop. And so It was in our area. It was a group called Parents Educating and Advocating for Children's Health, otherwise known as PEACH, that were really the main drivers of misinformation cloaked in religious ideology. And so when we were up against PEACH, we ended up making pie. And so this was a educational brochure that we did in collaboration with community members, where we went point by point on whatever PEACH put out to refute and give community members the data. And we found this to be a very effective tool. And as you can probably see there, it has no health department markings on it. And we did that intentionally because we wanted community members to use this as their own. And then these are some of the media materials that we put together in Yiddish as well as English for the community. And here, this is like my favorite curve, because the solid line are MMR vaccine uptake in Williamsburg during the outbreak. The dotted line is Williamsburg the year before. And you'll see there that we had fairly significant uptake when we first declared the outbreak in October, and that we also saw another spike with the emergency order. But if you look all the way to the end of the slide in September, you'll see that the back to school rush was actually lower than the previous years. And so that was, I think, the ultimate sign to demonstrate that the community had adopted the messages we were trying to convey and immunize their children in a timely way. And over the course of this, there were 188,635 MMR doses administered, which is citywide 23,000 more than the year before. And in Williamsburg specifically, there were roughly an additional 4,500. It was a Herculean effort on the part of our staff. We have amazing staff. At the end of the day, it was $8.4 million of unbudgeted cost. And there were, at the peak, 261 staff working on this at the same time. So, lessons learned. We can't take public health victories for granted, and the importance really for us was the need for more granular surveillance and immunization coverage. It wasn't enough to be monitoring immunization uptake at the community level. We had to really get granular at the school level and account for schools that had relatively little to no technology to do that tracking. And then leveraging community relationships to build new. We had actually on staff members of the Orthodox community, because we had had previous experience where that was really critical for the work that we do. And so this then gave us the opportunity to build on those partnerships and build new ones for subsequent outbreaks. And the challenge here going forward is that with the vaccine hesitancy, the need for ongoing resources to educate community members, I think, hand in hand with not taking victories for granted, it means that this year after year will need to be a significant investment on our part to ensure that we don't have any backsliding on community immunization rates and school-based immunization rates, in light of the fact that the measles outbreak is an international issue that continues. And so we, being an international city, need to make sure that we are always on alert for that. And then thankfully, New York State was able to join California, Maine, Mississippi, and West Virginia states that I never thought I'd put in the same sentence, in terms of having religious exemption removed. And we then, our Board of Health in New York City then also requires us to now review all medical exemptions for vaccinations in all schools, both private as well as public as well as non-public schools. And so that will require a significant amount of investments on our part to make sure that we don't see what happened in California in terms of seeing an uptick on medical exemptions for vaccinations. And so these are folks in various parts of our agency that played a pivotal role in the response. And I want to give a special shout out to Dr. Jane Zucker, who really has been a hero in this for many, 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 many hours. So thank you.
Good afternoon. I'm going to wrap this session up by talking about CDC's Vaccinate with Strategy strategy. First, I want to start by thanking Drs. Patel, Zucker, and Barbeau. Thank you, Dr. Zucker and Barbeau, specifically for coming down here, given all of the other things that we have going on at state and local health departments right now, but also not only for sharing your stories today, but also for sharing everything you've learned with us over the past year. As you'll see, it really informed our Vaccinate with Confidence strategy. Learning through all of this with you, as well as multiple other health departments that have faced measles outbreaks in the last couple of years. So I'm going to start by sharing some good news with you. Nearly 99% of U.S. children have received some vaccines by the age of 2, and over 94% of kindergartners have received both doses of MMR. But while these data demonstrate the strength of the U.S. immunization program, it also masks some vulnerabilities. For example, by the age of 24 months, only 90% of infants in the U.S. have received one dose of MMR. In some states, that number is just 85 to 89%. While we know that most of these children are caught up by the safety net of school-age vaccination requirements, toddlers are being left unprotected from measles during a time when they're most at risk for severe complications. Additionally, national and state data mask local pockets of undervaccination that exist across the country. In these communities, there is no blanket of protection from measles outbreaks once there is an introduction. As you guys have clearly heard, we know that each of these communities is unique, with distinct factors affecting vaccination coverage. These communities may be close-knit or isolated or distrust government. Access may also be an important issue in some of these communities. Localized misinformation about vaccine and safety and effectiveness, and a lack of understanding about the potential consequences of the diseases prevented by vaccines frequently contribute as well. Myths have always been a part of the vaccine landscape, but rapid dissemination and sophistication of misinformation in this current environment presents new challenges we need to address. Misinformation is eroding confidence in vaccines and putting our immunization program, and thus children's health, at risk. The outbreaks of measles you heard about this morning make it clear that educating the public about the importance of vaccines is not enough. We need new investments, innovative and culturally competent interventions targeting local and virtual communities. Vaccinate with Confidence is CDC's strategic framework for strengthening vaccine confidence and preventing outbreaks of vaccine-preventable diseases. This strategy has 3 pillars. The first is to protect communities. A measles outbreak should not be the signal that a community is at risk for undervaccination. We need to protect children by increasing vaccination coverage in these communities before the outbreaks occur. The second pillar is empowering families to be confident in their decision to vaccinate by strengthening the provider-parent conversation. All parents want to do what's best for their child, and we know providers are providing strong recommendations, but that's not enough with this environment of misinformation and all of the various sources of information that parents are getting. We know that it can be challenging to address all of a parent's questions when a baby is due for vaccines. Finally, we need to stop the myths. We need to build a network of local and trusted messengers to amplify accurate information about vaccines to parents who are grappling with understanding misinformation and myths. So how are we going to do all of this? I'm actually going to skip the next couple of slides and get to my final messages so that we have a couple of minutes to answer questions from all of you. So here's what CDC is doing. Over the next year, we're leveraging diverse data sources and protecting communities at risk, using local data such as IIS's. We're hoping to expand resources for working with communities and support our healthcare partners to build and foster a culture of immunization throughout the entire healthcare practice. We want to provide technical assistance to our immunization partners and engage new partners who can reach parents and soon-to-be parents in many different settings. But we mostly want to continue to rely on our public health partners working in state and local health departments and organizations who are on the front lines of this effort every day. Partnerships are key to increasing vaccine confidence. We need continued investments, new ideas and approaches, and we need to build an evidence base for successful interventions. As we ramp up this effort, what can you do to help? One of my favorite jobs outside of work is being a trusted information source for vaccines for parents in my children's school and community. The next time a patient, parent, friend, coworker, or relative shares misinformation about vaccines, I challenge you to stop, listen, and share information to help them understand that vaccines are safe and save lives. As was made clear by these recent measles outbreaks in New York State and New York City, the most effective vaccines don't work at all when they're sitting on a shelf. Thank you for your attention, and I want to leave these last few minutes to answer your questions. So I'll turn it over to you, Susan.
Thanks. I want to remind our online viewers you can send your questions to grandrounds@cdc.gov. One question from Tricia. Is there any risk of viral spread from a freshly vaccinated child to a parent with primary immunodeficiency?
I can take that question. So there have been no cases of vaccine transmission, which is genotype A. Certainly with immunocompromised hosts, we always worry about that because of their immune system's not able to fully contain the virus, but there's been no evidence or case reports of that.
We'll go ahead with another question. Specific to a bar chart that was showing that most measles cases were among unvaccinated, though some were vaccinated. Do vaccinated groups discussed include only persons with up-to-date vaccinations, or do people with out-of-date vaccinations contribute to that vaccinated group?
I will try to answer that question. So when our team classifies measles cases as unvaccinated or vaccinated or unknown vaccination status, it's if you're up to date. So measles being out of date, we don't have recommendations, for example, like an adult dose of MMR. Most adults just need one dose of MMR, or if they have other evidence of immunity.
Are there any questions from the audience? Are there more questions online?
Sure. From Lisa, this is via Facebook. Hundreds of thousands of students' health forms were examined for vaccinations. Does that research activity violate HIPAA?
I don't view it as a violation of HIPAA. First of all, that's usually it is important to look at the records of those who are in the schools, and usually the schools themselves were the ones who were doing the evaluation of that.
I want to remind, we had several questions about coronavirus online, and I would like to refer people to our website for the most current information, which is cdc.gov/coronavirus. You will find the most current information available there.
And can we take one question from the audience before we close?
Yes.
Okay, I'll talk loud. I had a question about the health system, the school systems that didn't have the proper technology, were there any like consequences for those schools, or are you guys working with the state to try to help them get up to par, or is there anything to help that gap?
So, yes, we are working with the schools to have them be able to access technology that will make tracking immunizations in the future much easier and more efficient.
And that tracker that I mentioned in that slide would be one of the ways to help on that.
We want to thank our speakers so much for a wonderful presentation and offering today. Let's give them a round of applause. We learned so much. And on behalf of the Office of Science and CDC, I want to thank you for attending both in person and online, and look forward to upcoming presentations in March, April, and May with equally exciting topics. So this brings our session to a close. Thank you so much.